So we come now to the last session for this very informative and fruitful Congress, and وختامها مسك مثل ما يقولون إن شاء الله. It gives me a great pleasure to introduce our speaker, Dr. Walid Kaplan, consultant pediatric endocrinologist and the chairman of the Department of Pediatrics at Tawam Hospital in Al Ain, UAE. Dr. Walid is going to be giving us a fascinating talk on the use of technology to enhance diabetes outcome, a very evolving field. Please, Dr. Walid.
Thank you, Nassim, very much. And thank you, Dr. Wian. And special thanks to all of you. It's the second day, it's the last session. You have not had any break for more than 2 hours, and we're already late, and you're still here. So let me tell you a joke before I start. It's not a joke, actually, it's a true story. You have to listen to the story, and this is true story, huh? So a speaker was invited to give lecture in North Dakota, a physician, in February. So, you know, North Dakota in February. He was very committed, so he struggled to reach the place because of the snowstorms, landed at the airport, struggled to find a taxi, and then eventually got to the hotel where the lecture is supposed to be, and then he found one person in the lecture hall. And he said, you know what, in appreciation of your dedication, I am going to give you my lecture, as if I have a full audience. He gave him the lecture, he answered his question, and then he was ready to pack his stuff and leave. And then the second person said, you can, and this is true story, by the way. No, you cannot leave. I am the second speaker, you have to attend my lecture. That's why I'm here in the room. So eventually the room had only 2 persons who were the 2 speakers, and I thank you. Some of you are here because you've given lectures, but I promise this will be a smooth and quick one. So I'm supposed to talk about technology and diabetes, so I'll have to give you an introduction and then give you historical background about the glucometer and insulin pump and show you where we stand today and what is expected in the near future. So according to the Type 1 Diabetes Exchange, which is the largest registry of Type 1 diabetes in North America, children or patients of all age group are basically uncontrolled. As you can see in the diagram, the dotted line is the target HbA1c, and there's no single age group that achieve or meet this HbA1c. And as you can see as well, that the worst or the least controlled group are the adolescents and the young adults. So we're still far away from achieving the target for everybody. If we consider the 4 elements responsible for controlling diabetes, diet, glucose monitoring, exercise, and medications, I believe technology overlap mainly with the blood glucose monitoring and with insulin delivery. Not much technology to talk about diet or exercise. So let me first talk about technology and glucose monitoring. And I'm going to skip the quiz and just tell you briefly or right away that the American Diabetes Association recommend that patients with type 1 diabetes should monitor their glucose 6 to 10 times a day. So a minimum of 6 monitorings or 6 tests per day. And basically this is the breakdown according to them before meals and snack and exercise and when symptomatic and at bedtime. So any of your patients should actually be encouraged to do a minimum of 6 readings per day to meet the target. And there is already a strong evidence showing the positive correlation between the frequency of glucose monitoring and the drop in HbA1c in adult patients, as well as in children and adolescents in any way you want to look at it, whether you consider those on insulin pump or MDI, those of different age group, toddlers, pre-adolescents, adolescents, or those that give the information directly from the patients or will take it from the meter. In all these categories, the correlation is still the same. The more testing means the lower the HbA1c. So let's talk about blood glucose monitoring. The first glucometer was made in 1970. So actually this is not something very old, relatively speaking. When you think of first insulin was in 1921, so 50 years after the discovery of insulin, here's the first meter, 1.2 kilograms, $500, and it was only intended for hospital and clinic use. It wasn't until 15 years later when the meters became available for home use, but those meters were still bulky, requires too much blood, and they were dependent or operator dependent, needing cleaning, warming up, calibration, and so forth. In the 1990s, the meters became more compact and easily portable and more accurate. But in the late 1990s, the first continuous glucose monitor was introduced, and that was blinded. So basically, the patient does not see the numbers. Actually, I used that in my fellowship training for the requirement to get my certificate, and it was a big excitement, and nobody can basically give it a penny of any significance. 2004, the real-time continuous glucose meter was introduced to the market, and then the most recent was in 2016, which is the flash monitor. So, summary speaking, the meters today compared to the older days are more accurate. They give results rapidly. They have large memories. They have software that provide lots of information. And on top of that, some meters have unique features, such as measuring serum ketone or giving a color-coded reading to help patients know what is normal, what is not normal, or even help patients do the dose calculations. In spite of that, and all the improvement, back to the Type 1 Diabetes Exchange, in their study of more than 20,000 patients of different age groups, the average glucose monitoring was 5.5 per day. So that's less than the minimum required. And the worst group were, once again, adolescents, young adults, and adults. So very few were meeting the minimum requirements in spite of all the advancement in the glucometer. Somebody might say because of the cost, but here's a study from Sweden where meters and strips are provided totally free of charge to all patients. And in this particular study, they showed that only 40% of patients are doing 4 readings per day, and less than 20% of patients are doing the minimum 6 readings per day. And the top 3 reasons for not doing the test were not financial, it's lack of time, not remembering the test, or self-consciousness causes. So there are limitations of the traditional glucometers. They're time-consuming. They don't show the trend of the glucose going up or going down. It doesn't give any warning sign when the glucose is trending according to or against the recommendations, unless the patient is doing the test. They do not synchronize with insulin pump except for limited functions and for 1 meter only. And it cannot be done for young patients or elderly patients. So here comes the CGM as being the solution for all these limitations. And before that, let me ask you these questions. How many natural islands does Bahrain have? 33. How many total islands does Bahrain have? Man-made plus natural. No, there are either 84 or 8, so there are more than about 50 man-made islands and 30 natural islands. Something exciting. I thought Bahrain is only one single, so I found this interesting. All right, so what is CGM? Basically, it's a sensor that goes in the subcutaneous tissue, and it measures the interstitial glucose concentration, and it has a transmitter that basically transmits the reading to a receiver. The unique feature of the CGM, it takes reading every 1 to 15 minutes, it depends on the brand. It does show glucose trend up or down. It does have alarm for the hypos and hypers, even when the patient is not testing. It gives a data of 1 to 2 weeks and a summary. Few of them might require, and this requirement is becoming less and less, might require glucometer to confirm the reading when it is not basically expected, or to calculate the insulin dose. So this is how they look. Basically, 3 brands are available in the market in the Gulf region. This is the sensor, that's the transmitter of one brand, and this is the sensor and the transmitter on the top of each another, and here's the 3rd brand. And that's how they look when the patient wear them. Basically, we only see the transmitter part. This is the new transmitter of Dexcom, which is not yet available, expected to be available this year in the USA, but you can see how much thinner and smaller, and it gives reading for longer period of time. And those are the 3 available devices in the market in the whole Gulf region. Once again, the transmitter, the reader, and the app of the smartphone. The transmitter, the reader, and the app. And this one has also a smartwatch that patient can see the trend and the alarm. And this particular brand comes with the insulin pump, so the transmitter, the pump has the screen where basically patient can see the trend and also the smartphone applications. You all probably know this, that the details we can generate from the CGM extremely more informative than we can see from the available data. I'm showing you 2 reports of 2 meters, but they show the same element, average glucose for 2 weeks or 1 week or whatever period you choose, average glucose, percentage of reading in range, percentage of reading in range, percentage of hypos and hyper, and here percentage of hypos and hyper. And here you see the ambulatory glucose profile, which is the summary of the studied period. The dark line is the average. The dark shade is the 25th to 50th percentile. The dotted line is the 10th to 90th percentile. Same thing here, average, 25th to 50th percentile, 10th to 90th percentile. And here you can see the individual day of the studied period. A lot of information that you can't even see, a small fraction of it with the alternative devices. So let's go, or options, I mean. Let's talk about CGM versus HbA1c. I'm going to show this cartoon to explain the difference. So here we see 3 profiles that have the same HbA1c of 7%, same average glucose of 154. However, one of them is fairly flat, and 100% of the readings are in range. The other one has some fluctuation, 70% of the reading in range, but 25% are high, 5% are low, and one which is all over the place, but still giving you HbA1c of 7%. But with the CGM, you can see how this patient is poorly controlled. So you can look more in depth into how the patient is doing when you analyze the CGM data versus looking at the HbA1c only. This is the recommendation now for the time in range according to the consensus of 2019. It is expected for the patients to be controlled that 70% of the reading should be in range for adults, whether they have type 1 or type 2, and 50% for geriatric and 65% for pediatric patients. The reanalysis of the DCCT data showed the same correlation with the complications. The longer the patient stays in range, the lower the risk of the retinopathy and microalbuminuria. So we believe that over the next probably years and decades, we will have a lot more information about the correlation between time and range and complications, which will support what we see in this proposed one here. Again, I'm not going to go over the details, only to show you the features of the available devices. They are very convenient, they are very advanced, and they are superior to all alternative ways of treatment now. Because of that, the use of CGM has become very popular. Here we see from 2011 to 2018, the use of CGM increased in the USA from 6% to 36%, that is 6-fold increase. And when you look at the different age group between children and adults, you can see the significant increase is in the younger age group. They were rarely using it in 2011, and up to 50% are using it now. So everybody is becoming more in favor of using it, and I think this trend will continue to incline over the coming few years. Is there evidence for the importance of this? Yes. This particular study comparing between patients on CGM, whether they're on MDI or pump, versus patients on pump alone or patient on MDI, and you can see that those on CGM, whether they use the multiple daily injection or the pump, achieve more rapid drop in their HbA1c, and the difference was maintained for 2.5 years compared to the other group. And at the same time, there was a significant reduction in the diabetes-related ED visits. Similarly, type 1 diabetes exchange showed the same data for 3 different age groups, younger than 13, and 13 to 26, and older than 26. Once again, the far to right bars are the CGM in each group, and the left 2 bars are either MDI with SMBG or MDI with insulin pump, and you can see that using CGM in any age group results in lower HbA1c compared to using pump and MDI or MDI and SMBG. So what are the recommendations of using the CGM? All now ADA and ACE and SPAD are in favor and strongly recommend the use of CGM in all patients who are on multiple daily injection, and in particular those with hypoglycemia and awareness. Let's move now to the other components. So we covered the technology and blood glucose monitoring. Let's talk about technology and insulin delivery, and that's going to take us to the insulin pump information. Another historical idea or information, the first insulin pump, ironically, was actually made before the first CGM. It's like almost 7 to 8 years, but this one is known to be the size of a small microwave or military backpack. It's totally unpractical, noisy, and inaccurate. It was about 15 years later when they made what is known as the brick pump, because it was very heavy and the size of the brick, and it was quite inaccurate. And it was only in the 1990s when the insulin pump looked similar to what we see today, and they were basically not having technical issues as they used to have before, and they started to deliver insulin very accurately, unlike the insulin pumps before. However, in the year 2000 and later, we started seeing the real improvements, which are summarized in this slide. So first of all, we saw the integration in 2006. And integration means now CGM data are integrated with the pump, so we can see the reading of the CGM on insulin pump. In the year 2009, we saw the sensor-augmented pump. Now the sensor not only shows the data, but it can actually turn the pump off when the hypoglycemia happens. And then a few years later, we started seeing we saw the predictive low glucose suspension. So now the pump does not wait for the hypoglycemia to happen to stop, but actually it stops infusing insulin before the hypoglycemia happens, when it is predicted to happen in the next 20 to 30 minutes. And the most recent one is the insulin or the Medtronic Minimid 780, which is no longer under investigation. It is already approved in Europe from 2020 and under FDA review for approval as we speak. So this pump actually has the predictive low suspension, but it also has the auto bolus that can correct the hyperglycemia. So what is available today? From the Medtronic system, we have the pump with the predictive low glucose suspension, which means the pump will suspend insulin before hypoglycemia happen and resume it once the glucose starts to go up in the safe zone. It has an automated bolus correction, so blood sugar starts to go up because patient eats a meal and forget to take insulin. Then the pump will give boluses every 5 minutes to basically counteract the increase in glucose concentration. Bluetooth to be interfaced with the smartphone, and this CGM lasts for 7 days, but it requires 2 calibration per day. In the US, there is the only touchscreen insulin pump available, and it's only available in the US. And this one can be upgraded by this changing the software so the patient does not need to get a new pump. And I found this very helpful when I started seeing patients using it. They just call the company, they upgrade the software, and now it is the most advanced one. It also has predictive low glucose suspension, automated boluses for the correction of hyperglycemia, but the CGM lasts for 10 days and it does not need calibration. So this is more convenient and more advanced. This is the only tubeless pump, Omnipod. This became available in UAE just 2 or 3 weeks ago. It does interface with the smartphone, and it does also interface with the Dexcom, which we're not sure if this is going to be available in the Gulf region, but this one does not have the feature of predictive suspension or auto boluses. However, many patients prefer it because it doesn't have a tube. It is water resistant, so they can swim and take shower with it. Once again, the CGM is for 10 days and it needs no calibration. Simply, just briefly, let me show you one study that basically crossed over the same cohort of patients. They used the pump with the feature of low glucose suspension off and low glucose suspension on, and you can see the significant difference of the time in hypoglycemia. When the feature was turned on, the duration of hypoglycemia was remarkably low. And a more recent study showed the hybrid pump, and again, those who use the hybrid pump compared to the traditional pump have more time in range, and this was more remarkable during the sleep hours. There are older studies that shows the difference between insulin pump and MDI very limited, and that's because they looked at the older pump. I believe the studies from this time onward will probably show more difference because of the features of the pump. I'm going to show you example meta-analysis of 8 studies that showed only mild improvement in HbA1c, but then everything else was the same. And study from the UK of 300 patients for 12 months compared or randomized between pump and MDI, and this one showed no difference in anything. Same HbA1c, same hypoglycemia, same everything. Once again, those are the older version insulin pump. I believe the newer pump will definitely show a very remarkable improvement. The use of insulin pump, while you can see the trend in adults has not changed much between 2000 and now, unless recently, you see the opposite in toddlers and younger children. Significant increase in using insulin pump. And when you look at the combination of insulin pump and CGM, the trend is even more remarkable in the last few years, and I believe this will continue to incline as well. So what are the recommendations? The ADA consider the insulin pump as an option. If the patient prefers it, it should be given. However, the SPAD has a stronger recommendation because they believe it does reduce the hypoglycemia and has a potential to reduce the complications, and it is appropriate for all age group. What about the ACE and the most recent recommendations? The insulin pump with the low glucose suspension feature recommended for all patients with type 1 diabetes because it reduces the severity and duration of hypoglycemia, and the one with the predictive low glucose suspension strongly recommended because it mitigates hypoglycemia. So that's what they put in their summary. Anyone with frequent hypoglycemia or hypoglycemia unawareness and those who have hypoglycemia fearness should basically consider to use insulin pump. So what is next? We're looking to see the smartphone to be used more to basically operate the pump rather than to have a separate device. Disposable CGM are already in trial, and we believe those will be available in the next year or two at the most. Those will be very compact and more convenient to be used than the current CGM. The pump should get more smart because we know most of the patients who are under controlled on insulin pump, they are under controlled because they do not do the carb counting and they do not enter the glucose reading in the pump, so they end up being hyperglycemic. I think the smarter pump will be giving more aggressive boluses to counteract those increase in hyperglycemia. patch pump and more tubeless pump probably becomes the pump of choice. Having a bulky pump with a tube hanging from it is basically one of the main reasons why adolescents do not like to use insulin pump, and I found this more true in the US. So in summary, technology has led to improvement of glucose monitoring and insulin delivery, there is no doubt. It has led to less patients and guardians involvement, better time and range with less risk of hypoglycemia, and reduced fear of hypoglycemia with better quality of life. Now to see how much awake you are, I'm going to give you 10 seconds to look at the next slide, and then I will ask you a question about it. 9, 8, 7, 6, 5, 4, 3, 2, 1. Which word did not exist in the previous slide? What is it? What is it? Transmitter was there. Glucometer was there. No. Syringe. Syringe was not there. All right. Just to wake you up. Thank you so much.
Thank you very much, Dr. Walid, for this interesting and informative talk. Any questions from the audience? So in your clinical practice, do you have most of these pumps available in UAE? You don't have the Tandem, right? But you have the Omnipod and the Medtronic.
Yeah, so Tandem is only available in the US, actually. It's not even in the Europe. And Omnipod, as I said, became available 2 or 3 weeks ago. However, the synchronization with the Dexcom might not be available, even though it's only a software. So we're going to see once it becomes in the market in our pharmacies to see if this can be modulated.
So in your clinical practice, do you see a difference in HbA1c achievement in patients on MDI versus the pump? Forget about the research, but in your clinical practice.
Very, very good question. Actually, we did SKMC in Abu Dhabi and Tawam in Al Ain. We looked at our patients, and out of the 243 patients we have in our center, 36% of them are on the pump, and there is no difference in HbA1c. And same findings in SKMC. There is no difference in HbA1c. So again, I would probably say that the pump we have been using until now requires a full engagement of patients and or families. And unfortunately, this is not the case. They want the pump to do everything to them, and we keep telling them it's their job to enter the carb, it's their job to do glucose monitoring and enter it. The newer pumps are covering those gaps gradually, and I think it's going to be even more effectively over the next less than 5 years.
Can I come back to you? Thank you very much. Excellent talk. Some of my patients, they use the device to measure and to know what kind of food which raise the blood sugar. So they take whatever rice or whatever and certain amount, and they see after 2 hours how much did this substance rice or bread, how much raised, and so they avoid them. Don't forget, the instrument is expensive, relatively expensive. For Bahraini, you're talking about every 2 weeks they have to pay 25 dinar. So talking monthly, 50 dinar. So yearly about 600 dinar. Some of them, they found it is very cheap, and worth it for them. But it's good, some even normal people, they've been using it with no diabetes, to know what kind of food, raise their blood sugar. I think it will have many applications. And we just, this is the start, and I expect, probably other features will come, like ketone. If you could measure ketone with the same device, it will give you an idea
I totally agree with you. I cannot comment about using CGM by non-diabetics, but if I see patients of mine who want to use CGM just to know which food increases his sugar more, I would support him, because we know the more the patients know, the better they are controlled. And that's why I showed you in the slide. The more SMBG they do, the lower the HbA1c, because now they can see their numbers high, so they might ignore half of the readings but take insulin for the other half. So fine, if they want to use it for that, I would support them. But I agree with your comment.
Yeah, Dr. Delal? Yeah.
Thank you for your excellent talk. So at King Hamad University Hospital, we started using the 7-ATG, and the results are fantastic, and it's much user-friendly, less work on the patient. Still, of course, they have to do their carb count, but if they over or underestimate, the bump is forgiving because it can overcome the highs and lows. I've been trying with Omnipod for 8 years to attract them to Bahrain, and I've failed, and they say they're not interested in the region, but luckily they are now interested in the region. So if you can connect us with them, I'll be more grateful to bring Omnipod to Bahrain. Don't you all agree? Yeah?
Definitely.
We should.
It's a tubeless,
Yeah.
the most amazing pump.
And then if you could give us some tips and tricks, because some people on flash glucose monitors get these nasty skin irritations, and that discourages them from using the technology. Any tricks on you can share with us?
If you heard the question, because there's echo, can you?
Skin irritation with the Freestyle Libre or the flash glucose monitor, skin irritation.
Skin irritations.
Tips?
From the CGM itself?
Yeah.
Yeah, well, some patients actually have atopia, and we know that they basically overreact to even clothes or something. So I usually send them either to dermatologists, or I tell them two things they have to do. Rotate the insertion site, but as soon as they remove the old sensor, I usually tell them use hydrocortisone for 2 days, and then use moisturizer every single day until before the application of the new sensor, and this actually is very helpful. But if they just take it out and it's already irritated and a mild eczema already there and they do nothing, by the time they use it again, it's going to become worse and worse.
Okay. Thank you very much, Dr.